So baby presently 21 days old neonate admitted at 6 hours of life, gestation 37 weeks with birth weight of 2.74 kg. So it was born by spontaneous vaginal delivery at outside hospital. Baby cried immediately after birth. Apgar was not available. Birth weight of 2.74 kg. It was referred to our hospital at 6 hours of life in view of swelling over the right forearm. So coming to antenatal history, the mother is 23-year-old G2P1L1 mother. She was a registered case and immunized. She has taken iron and folic acid supplementation regularly. She was a known case of hyperthyroidism on tablet propylthiouracil. The antenatal USG done were normal and AFI was adequate. There was no significant family history. So coming to the examination proper, baby on admission, the vitals were normal. Baby was hemodynamically stable, maintaining saturation on room air. This was the anthropometry which was plotted at the time of admission, showing the birth weight, length, and the head circumference. So this is the baby with a local lesion over the right forearm, showing the fungating mass, which is friable in nature, almost 12 into 10 centimeter, bluish with associated with ulceration and bluish discoloration. So on palpation, there was a thrill present. On auscultation, audible bruit was present. So with this history and the local examination, we came to the working diagnosis of suspected arteriovenous malformation. As there is a soft tissue involvement, we also kept in mind the diagnosis as caposiform hemangioendothelioma, which can present at birth. Later, we move on with the investigations. We did hemogram, septic screen we sent, PT, APTT, INR, D-dimer and fibrinogen levels were sent. So hemogram was suggestive of HB20, platelet of 1.2 lakhs. Elevated D-dimer levels, it was 53,366 nanogram per ml on admission. Fibrinogen was 316. PT was 20.7. APTT was 67.8 and INR was 1.7 on admission. So later, with this baby with 6 hours old with history of local fungating mass and elevated D-dimer levels on admission, with the working diagnosis of suspected AV malformation, we move ahead with the initial modality of ultrasound to localize the lesion as well as to see whether the AV malformation, whether it is a high flow or a low flow. So this was the ultrasound Doppler which was done on admission, showing increased blood flow over the local lesion. It was suggestive of there is an arteriovenous connection as well as increased blood flow, suggestive of high AV malformation. Later, we move ahead with the further investigation. We did MRI of the right upper limb. So this is the image showing the soft tissue. So soft tissue involvement with the flow void, you can see here, and there are dilated tortuous veins, you can see. So these dilated tortuous veins, they are present in the intramuscular and subcutaneous planes, and they are draining into the superior vena cava, and you can see the dilatation of the internal jugular vein also. So we could not appreciate the arterial blood supply in this MRI as the baby was not comfortable, and we did only later MR venography. This MR venography is showing dilated tortuous veins over the local lesion. It was extending up to the upper arm. So all these draining veins into the superior vena cava, as you can see in this picture. So this was the MR venography diagram showing the dilated tortuous veins. So with this investigation of MRI and as well as USG, we came to the working diagnosis of a term baby with AGA appropriate for gestation age with arteriovenous malformation with intravascular coagulation. So let's discuss about the course of the hospital of the baby. So the baby was hemodynamically stable on admission. He was maintaining saturation on room air. We started the baby on full RT feeds and under warmer care, we continued the support. So at 24 hours of life, baby developed respiratory distress. So at that time, we did the chest X-ray the chest X-ray which was done show here, it was non-specific. So because of the increased respiratory distress and the increased tachypnea, we took the baby on CPAP support. So later, at this point of time, we thought the baby at 24 of life with AV malformation, suspected AV malformation, and with local examination suggestive of fungating lesions, we thought the baby can go into high output failure because there are various case reports and various case reports have been done previously. It was showing the venous malformation going into high output failure because these AV malformation, there will be shunting of the blood from the arterial to the venous connection, thereby it increasing the blood flow to the right part of the heart, increasing the preload, and later leading into high output heart failure. So we have to differentiate these AV malformation. Basically, our case is extracranial one, which is a peripheral AV malformation. We have to differentiate this AV malformation from the cranial AV malformation because these cranial AV malformation have a high tendency to go into high output heart failure. So in this case, we monitor this case for increased oxygen requirement. We did the chest X-ray, and later we did the echocardiography to look for the cardiac output as well as the right ventricular and left ventricular functions. So there was no suggestive of heart failure. So as there are very few case reports have been done in the literature, so we have to be cautious while managing the cases with AV malformation because they can go into high output heart failure at any point of presentation. So we manage this baby with non-invasive support finally. So at day of life 2, the baby had increased bleeding from the active local site, that is from the malformation site. That was around 20 to 25 ml per kg. So we have to actively control the bleeding by using compression bandage. And as the PT and APDT were also deranged, we transfused with FFP and PRBC. And as you can see in this picture, we have did compression bandage as well as limb elevation. So this compression bandage definitely, as per the evidences, there are no role. But at this point of time with active bleeding, we have to control the bleeding at that momentarily. So we did the compression bandage to diminish this intravascular coagulation as well as to protect the baby from minor trauma to the skin, as well as to decrease the size of this venous malformation. So we recap with this D-dimer. So as you all know, the D-dimer indicates the intravascular coagulation as well as thrombolysis. And this D-dimer is an indicator of a microcirculatory failure. So as we all know, these D-dimer values will be elevated in cases of disseminated intravascular coagulopathy and as well as in cases of this AV malformation where there is a case of intravascular coagulation and thrombolysis will happen. So in our baby also, the day of admission only, the D-dimer was elevated. It was very high, 53,366, which was almost 10 times the normal values. So as you can see in the normogram, so 2.44 to 2.45 milligram, it was in the first week. So later the D-dimer values goes on decreasing. So by 4th week of life, the D-dimer values will be 0.8 to 0.6 milligram per liter. So these D-dimer values had a significant role in evaluation of this AVM. So D-dimer evaluation should be done. And there is a role of anticoagulants also, as in these case of D-dimer elevation. So you can see in this review article, what they have suggested is whenever the D-dimer values are more than 4,000, so always you have to assess for the risk factors. So first we will do the imaging diagnostic, that is ultrasonography. So and we will assess whether there is any thrombus present or not. So if the risk factors are present and if the thrombus is present, then we will start the enoxaparin at a therapeutic dose until the resolution of the thrombus. And if there is no thrombus, then enoxaparin is given at least until the control tests are performed. So then we have to repeat the D-dimer concentration. So if the D-dimer concentration is normalized, if it is less than 500, then we have to stop the enoxaparin regardless of risk factor. If it is falling in between again 500 to 4,000 nanogram per milliliter, then we have to give the prophylactic dose until the resolution of the risk factors. So if the thrombus is present, then definitely you have to start enoxaparin at therapeutic dose until resolution of the thrombus, but not less than 14 days. Again, you will do ultrasonography and you will reassess the thrombus whether it has subsided or not. If the D-dimer concentration, if it has decreased, then you will end the enoxaparin dose regardless of the risk factor. This is if the risk factors are present. If there are no risk factors, then also you will assess for ultrasonography and we will assess for later thrombus in ultrasonography, and accordingly we will treat with if there is thrombus, we will do enoxaparin at therapeutic dose, or if there is no thrombus, then we will use the enoxaparin at the therapeutic dose till it normalizes to less than 400. So finally, we will do the ultrasonography again. If the thrombus has subsided or not, we will watch. So if the D-dimer concentration is less than 4,000, then we will stop the enoxaparin. And if there is any further thrombus buildup, then we have to do the anti-factor 10A activity and possible modification of enoxaparin dose we have to consider, and we have to think in terms of heat, that is heparin-induced thrombocytopenia should be considered. So this is the algorithm showing whenever there is high D-dimer concentration in units, if it is especially more than 4,000. So basically you have to assess for risk factor, you have to do the imaging diagnostic to assess for the thrombus, accordingly you have to treat. So next, in the course of the hospital, baby had active bleeding, further active bleeding on day of life 3 as well as on 4, even after compression bandaging, limb elimination, even after all the control measures. So we consulted the pediatric hemato-oncologist, intervention radiologist. Then we came to the conclusion to start a trial of sclerotherapy because there was active bleeding from the malformation site. So sclerotherapy plays a role whenever there is active bleeding from the malformation site. So as you all know, sclerotherapy has indications. We have therapeutic indications as well as aesthetic indications. So therapeutic indications, it includes the vascular malformations such as low flow lesions, such as venous malformation, lymphatic malformations, and benign vascular tumors. As aesthetic indication, mainly in telangiectasias, we'll use this sclerotherapy. So this is the image showing the sclerotherapy, which was done under USG and fluoroscopic guided fluoroscopy using the cetrol and lipidol solution. Cetrol is basically the sodium tetradicyl sulfate, and vividol solution is polyester of ethanol of poppy seed oil, which have been used for the sclerotherapy here. So basically using the scalp vein needle, they have injected this sclerosant agent at the point of the nidus. So as you can see in this diagram, and they have blocked the feeding arteries and vessels. So as you can see in this picture. So there are various sclerosant agents they have been used in units. Basically, this is the big list of sclerosants which are used commonly in units. As you can see, the most commonly used, historically used, was ethanol, sodium tetradicyl sulfate, polidocanal, loromacrogol, OK432, bleomycin, and doxycycline. So among these, we have used here basically the sodium tetradicyl sulfate was used in our case. So as you can see, the side effects of these corresponding sclerosants. So we have to watch for basically the limb perfusion, radial. In our case, we have watched for the complications such as the pulp. We did the clinical examination and we watched for perfusion and pulses of the right upper limb. So as you can see in this diagram, STS has known to cause skin blisters, hemoglobinuria, skin ulceration, pigmentation, local infection, scar, necrosis, and bleeding. So as documented in this figure, ethanol, you can see ischemic bullae, necrosis, DVT, pulmonary embolism, facial nerve palsies, bradycardia, cardiac arrest, hypertension, and pulmonary vasospasm has been documented. And bleomycin, known to cause pulmonary fibrosis, scarsing, and pulmonary hyperpigmentation. And the antibiotic like doxycycline, cellulitis, pain, swelling, skin blisters is known to cause Horner syndrome and hematoma. So polidocanol is known to cause injection site hematoma, skin irritation, and skin dilation. So these are the various agents have been tried. So among these, we considered sodium tetradiesel sulfate because when compared to other sclerosants, it has less side effects and it is easily available. So basically, this sclerosants, they will damage, how they will act. So they will damage the endothelial wall and they cause thrombosis. Thereby, they will cause the death of the vessels. So when you are giving a sclerosants, you have to watch for complication. Basically, vasospasm, ischemia, and mainly the pulmonary embolism. You have to look in sclerotherapy. So after the first trial of sclerotherapy, there was a reduction in the size of the AV malformation, but the baby required multiple sessions for the reduction in the size of malformation and to block the feeding vessels. So on day of life 17, we considered percutaneous embolization of the feeding vessels using the glue. So glue embolization was done on day of life 17. So there are various agents that have been tried for embolization. So this is the classification of embolic agents. As you can see, we have mechanical embolic agents and flow-directed embolic agents. So mechanical embolic agents, they have been used in the treatment of the focal vascular abnormalities. The embolic agents such as coils, plugs, gel foams, they have been used. In flow-directed embolic agents, you have particulate embolic agents and liquid embolic agents and gel foams. Basically, they have been used in diffuse vascular abnormalities like AVM, tumors, solid organ pathologies. So this is the list showing the different flow-directed embolic agents. In particulate embolic agents, you have PVA particles, spherical embolic agents, drug-eluting, reabsorbable microspheres. And liquid embolic agents, you have N-butyl, onyx, and sclerosants. And gel foams, you have also been tried as an embolic agents. So after discussing the agents used in neonates, what are the different embolic agents and mechanism of action, and we'll discuss about the complications. So complications of embolization, the most common is the local site infection and bleeding. And secondly, the ischemia due to distal migration of these embolic agents. And as you all know, contrast, so every contrast will induce renal toxicity, the contrast induce renal failure. Sometimes this contrast might be allergic, so it can lead into anaphylactic shock. So there is a tendency for this sclerosants to go into pulmonary vessels and cause pulmonary embolism, and they can also cause a post-embolization syndrome. So in post-embolization syndrome, the babies will be presented with fever, leukocytosis, and there will be increase in the cell count. So this post-embolization syndrome will resolve on its own within 1 week. So this is the image showing the percutaneous embolization using the glue. So as you can see in this diagram, there is a nidus here. Using a scalp vein, the glue is injected and is blocking the feeding vessels. So with the due course of time, so before doing this percutaneous embolization, we have considered the oral sirolimus for the reduction in the size of this AV malformation. As we all know, oral sirolimus is an mTOR inhibitor, which is belonging to class of immunosuppressants. So we have tried oral sirolimus also in this baby for the reduction of the swelling of the local site. So dose what we have used is 0.8 mg per meter square 12 hourly. So this sirolimus have to be titrated according to the serum trough levels. So serum trough level should be maintained between 5 to 15 nanograms per ml. So duration, we can use this sirolimus till there is a subsequent reduction in the size of the swelling and there is improvement in the clinical symptoms. Side effects of sirolimus, which includes mainly the hypertriglyceridemia. You have to monitor for triglyceride levels. Then you can there is hypertriglyceridemia, dyslipidemia, hyperglycemia, limb ischemia, pulmonary vasospasm. It can cause pulmonary hypertension. So we have to look out for these side effects in sirolimus. To further plan regarding the management of the baby. So currently the baby is 21 days old. So underwent 2 sessions of one session of sclerotherapy followed by second session of embolization. So this is the post sclerotherapy image. You can see there is a significant reduction in the size of the swelling when compared to the day of admission. But there is a SCR formation, as you can see in this figure. So later the baby might require skin grafting. So we have planned for a few more sessions for percutaneous embolization. Definitely the dilated tortuous veins, the edema part has been reduced. Plan is to continue the sirolimus, and we have counseled the relatives for excision also in the later part, and we have discussed with the pediatric surgery team also regarding excision, but the parents were not willing at the time of admission, so we go ahead with the sclerotherapy and other line of management. So I will hand over. Excuse me, ma'am.
Yeah. Yeah.
I will hand over to Dr. Suprabha, ma'am, for the things.
Yeah. Next slide, Karthik. So, like as you all must have seen, there have been multimodal treatment. We have used sclerotherapy, embolization, medical management. So, one thing which is very important to stress upon in such a complex AV malformation is the goal of treatment, where it is regarding the reduction in the lesion size and to reduce the associated symptoms. Like in this scenario, the baby had bleeding, the baby had a lot of pain. All these things had to be catered for, and here the aim is not a total cure, which is like not possible. Here we have to aim for reduction in the size and in reduction in the associated symptoms, where multiple therapy sessions might be required. And in case of this baby, I mean, it's a patient satisfaction and a symptomatic improvement, and not just a change in the imaging finding. These things have to be taken into consideration. Next slide, Karthik. And just in short, regarding the classification which is used for vascular anomaly, the International Society for Study of Vascular Anomalies classification is there, which Dr. Karthik will be telling us in brief in the later part. Can I have the next slide? And very important thing which we all must have understood till now, that there is a lot of role of radiologist in the diagnosis of such vascular anomaly lesions. One thing is important for the accurate diagnosis. Second thing is the role comes in terms of the treatment planning. And here in cases of AVM, first line treatments, sclerotherapy or percutaneous treatments, and it is a multidisciplinary approach, which is essential. And can I have the next slide? Yeah, so for today's session, we have with us Dr. Vivek, who is an interventional radiologist. So can we have Dr. Vivek? So I'll request Dr. Vivek to share his challenges during the diagnosis and management of this case, and if he can share his own experience with respect to vascular malformations.
Yes, ma'am. Hello. Ma'am, am I audible?
Yes, yes, you're audible, Dr. Vivek.
Yes. So basically, the case was referred. When there was case was referred, we have initial dilemma whether it's a clear-cut AVM or it's some vascular hypervascular neoplasm, because there was a large soft tissue component. In such cases, in case of adult counterparts, usually we go ahead with the diagnostic DSA, that is digital subtraction angiography. We study the hemodynamic pattern of the lesion, whether it's a high flowing or low flowing. If it is high flowing, definitely the transarterial treatment will be the choice, because it gives a more controlled and clear anatomical detail. But since the neonate is very young, it's hardly, and weight is 2.7 kg, so we have the limitation for the angiography, because maximum we can use a 10 ml of the contrast, and that 10 ml of contrast will be exhausted in the few diagnostic runs, because we have to see multiple planes. Second hurdle is puncturing the artery. To go from the femoral artery to the brachial artery, we have to puncture with a small micro puncture set. arteries are very fragile, prone for vasospasm and dissection. So that is again a different challenge. And this procedure has to be done under general anesthesia. So because of this hurdle, we decided to go ahead with the percutaneous treatment, which is well established in the literature. The similar kind of treatment we use for the scalp vascular malformation, that is AVMs. We call Sirsa